Okay, this is part 2 of the cardiac lecture. Before I get into the pharmacology, I just did want to do a little bit of a review of some key points that I might not have hit very strongly in the previous section. So when we talk about myocardial infarction, we have non-STEMI versus STEMI, which is non-ST elevation MI and ST elevation MI. But prior to that, we have angina. And angina is essentially chest pain that indicates we have ischemia going on. Angina can either be stable, which is usually intermittent. It's usually provoked, meaning we did something, we had physical exertion, we were under a lot of stress, whatever. It's usually got a similar pattern, similar onset. The patient will usually know what they did to bring on their angina, and it will subside with rest. With unstable angina, just as the name implies, this is unstable. There is nothing that provoked it. It just happened. It's new onset. It'll usually last greater than 10 minutes, and rest or relaxation doesn't make the pain go away. This is urgent. This is indicating that we have significant ischemia happening, and this is indicating that we have a heart attack either happening or about ready to happen. Again, back up to non-STEMI versus STEMI. So non-STEMI basically just occurs when you've got occlusion of a minor coronary artery or a partial occlusion of a major coronary artery. This can cause damage. This is still considered a heart attack. There is no such thing as a mild heart attack or a almost heart attack. A non-STEMI is still a heart attack. With a STEMI, this occurs when there is complete occlusion of a major artery, and this will cause full thickness damage to the myocardium. So I just wanted to make those couple of points clear. Okay, let's go ahead and get into pharmacology. So the patient comes in and they're having chest pain. First thing we're going to do pharmacology-wise, the acronym is MONA. Morphine, oxygen, nitrogen, aspirin, but not necessarily in that order. We're probably going to do oxygen first. Did I say nitrogen? I meant nitroglycerin. Oxygen first, then probably the aspirin and nitroglycerin and morphine. The main thing is to remember that it's not going to be in the MONA order. That's just the easiest way to remember it. But oxygen will come first. There is a PowerPoint presentation on cardiac drugs that will go into these medications much deeper. This is just supposed to give you an overview of how they're going to be used during a myocardial infarction. Okay, so MONA, again, not in that order. Oxygen will come first. We're going to get oxygen into that myocardium. This will also help relieve some of the pain. Probably go ahead and give them nitroglycerin IV or sublingual underneath the tongue. Nitro is a vasodilator. If you'll recall, it relaxes smooth muscle. So because of that vasodilation, it will increase the blood flow, which will hopefully increase myocardial oxygen supply. The next thing we'll probably give them is morphine. Morphine will help with pain. It will also decrease the oxygen demand of the heart. And aspirin. Remember, aspirin is an antiplatelet, so it keeps the platelets from clumping around, which is what's causing the heart attack blockage probably in the first place. Other medications that we're going to see with myocardial infarction are beta blockers. These are the ones that end in OLOL. We give beta blockers because they decrease myocardial oxygen demand by lowering heart rate, blood pressure, and they reduce the force of the contractility of the heart. If you'll recall about what beta blockers do is they slow that conduction through across the electrical conduction of the heart. So if your patient is in a complete heart block, you don't want to give them beta blockers, because if they have the heart block, we don't want to then further slow down the electrical conduction. Giving them beta blockers reduces the risk of reinfarct and heart failure. If they get discharged on a beta blocker, they will be on a beta blocker for probably as long as they're alive. Calcium channel blockers, these end in PINE. Your calcium channel blockers are going to cause smooth muscle relaxation. We can use calcium channel blockers if beta blockers are not tolerated. These also cause vasodilation, which decreases systemic vascular resistance, which helps lower the blood pressure. And again, with that, it reduces myocardial contractility force and also causes vasodilation in the coronary arteries. Plavix, which is the brand name for clopidogrel. Plavix is an antiplatelet aggregate. Very frequently you will see patients on clopidogrel and aspirin because they kind of attack the whole clotting cascade in different parts. ACE inhibitors. ACE inhibitors are, if you remember, the renin, angiotensin, aldosterone system. If you don't remember that, you really need to go back and review it. Just briefly, renin is released by the kidneys secondary to sympathetic nerve stimulation as a result of decreased pressure in the renal artery. So this is maybe because of reduced sodium to the distal tubules or whatever, but the pressure starts to drop. And so renin gets released by the kidneys, which causes angiotensinogen to be produced by the liver, and it breaks it down into angiotensin 1. Angiotensin 1 gets converted to angiotensin 2 by an enzyme called, wait for it, angiotensin converting enzyme. Again, ACE, the angiotensin converting enzyme, is found mainly in the lungs. So that enzyme converts angiotensin 1, which is basically inactive, to angiotensin 2, which is very active. This is a major vasoconstrictor. So because of that vasoconstriction, that causes increased production of sympathetic activity, remember the fight or flight, increased sodium reabsorption and potassium excretion, which causes water retention. It causes your arterioles to vasoconstrict. So angiotensin 2 will cause blood pressure to go up. So what we want is for that to not happen. So ACE inhibitors prevents that conversion from happening, and that prevents the blood pressure from going up. If a patient has just had a heart attack, we don't want them to have this arterial vasoconstriction. We want to let everything just kind of relax and chill. So that's why they get put on ACE inhibitors. If you'll recall also from the cardiovascular drug PowerPoint, ACE inhibitors have some protective mechanisms over the microcirculation as well. We'll also put these patients on heparin if we have clotting issues that need to be addressed immediately. See, the glycoprotein 2B and 3A agents, these are the drug names RioPro and Aggrastat. So tirofiban is the actual generic name, which is what you need to be most familiar with. These are antiplatelets. If we think that the patient is going to go have PCI done, then they will get this medication before, and usually we give it after to help prevent thrombus formation. And then Colace is another medication that we give patients after a heart attack. Why do you think we're going to give them Colace? Well, we don't want our patient trying to push really hard to poop out a big old mess when they've just had major surgery or had damage done to their heart. So we give them Colace to prevent them from straining. We also give them statins, which is not listed on here. If they have hyperlipidemia, we'll give them a statin. Usually they want the LDL. If the LDL is greater than 100, we will give them a statin. And again, that's to help prevent further atherosclerosis. Heparin, let's go back to heparin really quick. So do you remember what the test is that we run to see if heparin is doing its job? PTT. And then do you remember what the antidote is for heparin? Protamine. And if we're giving them Coumadin, do you remember what the antidote is for too much Coumadin? Vitamin K. These are important things for you to remember. So let's talk about the healing process. So now I've had my heart attack. What's going to happen next? So the healing process, the body's response to cellular death, which is what happened because we just had a big old heart attack, is the inflammatory process. If you don't recall the inflammatory process, in your Lewis textbook, it's chapter 11, I believe. So within the first 24 hours, leukocytes will infiltrate the area and the dead heart cells release because the dead heart cells release enzymes that are, again, that's what we're looking for whenever we do the diagnostic lab draw on these patients. Remember the cardiac biomarkers? You want to make sure you remember those if you don't remember what I'm talking about. So those enzymes of the neutrophils and the macrophages begin to start like little Pac-Man. They go in and they remove the necrotic tissue by the 4th day. During this time, that muscle wall where, granted, the little macrophages and the neutrophils are chomping away and removing that necrotic tissue. Well, now that area of the muscle wall is very thin, so we have to be very careful with these patients for a little while during this process. The serum glucose levels are frequently elevated after MI, and again, look at your inflammatory process and you'll remember that the catecholamine-mediated lipolysis and glycogenolysis occurs, which causes increased plasma glucose and free fatty acids. But you need to go back and review that process if you don't remember what I'm talking about. So the necrotic zone of a STEMI is identified on the EKG changes. Remember we talked about the Q wave, the T wave inversion, the lowering of the ST segments within a day or two. So at this point, the neutrophils and the monocytes have cleared away all that necrotic debris, and now we start laying down the new collagen matrix that will help form the scar tissue. At 10 to 14 days, the new scar tissue is there, but it's still kind of weak. So the heart muscle is very vulnerable right now, and the patient's activity levels just need to be increased very, very slowly during this time. By week 6, scar tissue has completely replaced that necrotic area, and basically the injury is healed at that point. But just remember that scar tissue is not as soft and springy as original tissue, so you are going to have a more stiff area, which is going to contribute to your heart's ability or inability to pump effectively. So if the heart is unable to pump effectively, this is what is considered ventricular dysfunction. So remember that the normal heart tissue is nice and spongy and springy and soft, but once we have a damaged area and then it gets scar tissue built over it, in order to compensate for that damaged muscle, normal myocardium starts to hypertrophy in that area and dilate. This process is called ventricular remodeling, and it can lead to the development of late heart failure. So this is why we put our patients on ACE inhibitors or ARBs to prevent that ventricular remodeling from getting too crazy. So further complications, dysrhythmias. I talked a little bit about dysrhythmias in the previous section. So we've reperfused this heart, and now it is not uncommon for them to have dysrhythmias until the heart kind of just basically gets itself back together. Heart failure, I just talked about because of the remodeling that happens. The heart's pumping action is probably going to be reduced if they just had a heart attack. So again, with the dysrhythmias, these are obviously the most common complication that you'll see because those myocardial cells are very sensitive to nerve impulses. And when we reperfuse that area, that whole intrinsic rhythm of the heart gets disrupted, and it can cause tachycardia, bradycardia, it can cause PVCs. All of this will usually work itself out. Heart failure is another complication, and again, the heart's pumping action has been reduced. We've damaged that heart muscle. So you'll end up with decreased function. That, remember we called that EF, ejection fraction. Anything when you have an ejection fraction below 40%, it is not functioning correctly, and they need to be on some medications to kind of help compensate for that disrupted pumping action. Cardiogenic shock. This occurs when oxygen and nutrients supplied to that heart tissue are inadequate, and you end up with severe left ventricular failure. This occurs less often as long as we can get in there quickly and treat the MI. Remember, cardiogenic shock is a problem with the pump. If the patient does go into cardiogenic shock, this has a very high mortality rate, so we have to be very aggressive with our management. We need to control the dysrhythmia. There are interventions that we can do to help the pump be more effective. One of those is called an intra-aortic balloon pump, and that actually is a big long pump that goes in the aorta, and picks up the pumping timing with the heart, and it actually just kind of helps give an extra push if that left ventricle isn't doing its job very well. And you'll know a patient is on it because you'll be in their room and you'll hear it going ba-rum, 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 and it's timed off of the patient's heart rate. It's actually a pretty cool device. There are also contractility and vasoactive drugs that we can give. Remember, the goal of therapy if a patient is in cardiogenic shock is to maximize oxygen delivery and reduce oxygen demand to prevent further damage to that heart. Papillary muscle dysfunction, these on the slide you can see these are the little papillary muscles that hold the mitral valve. You can suspect papillary muscle dysfunction if you can auscultate a new murmur at the cardiac apex. And if you hear this, then the doctor will probably go ahead and order an echocardiogram to confirm the presence of papillary muscle dysfunction. And then ventricular aneurysm. This results when the infarcted wall is very thin. Remember I told you as the macrophages go in there and they clean out that necrotic tissue, the wall becomes very thin. It'll actually bulge out a little bit during contraction. This can develop within a few days, weeks, months. It can develop, it just depends on how deep the damage is and how long it takes to heal. The patient may go into heart failure for a while. They can have dysrhythmias, they can have angina. Worst case scenario is ventricular rupture, and as you can imagine, ventricular rupture is fatal, so just be aware of that. So, nursing interventions. What will you do for the patients at different points of care? So we start off in the emergency room. Remember, in the emergency room, Mona is your friend. Oxygen, morphine, nitro, aspirin. The number one thing is to reduce their pain. Once you've relieved that pain, you might have to deal with a little bit of denial because a lot of the patients just don't understand that they are indeed having a heart attack. And don't forget what Mona stands for. And don't forget why we give which ones we give. Anybody who's worked in a hospital knows what the Joint Commission is. They have a set of core measures for myocardial infarction. Now the core measures are abstracted electronically, but it used to be a person had to go through the chart of every patient who was diagnosed with myocardial infarction and actually find these data points to make sure that all of the best evidence-based practice was met. I know this because I have done this, and it was actually really, really interesting. But just briefly, the Joint Commission core measures for myocardial infarction. So they need to have an aspirin at arrival if they didn't do it prior to coming to the emergency room, 4 baby aspirins or 300 milligram normal aspirin. They should be prescribed on an aspirin daily at discharge. They need to be prescribed an ACE inhibitor or an ARB for left ventricular systolic dysfunction. They should actually have that started within the first 24 hours. And if you'll remember, the EF that we're looking for is 40%. If it's less than that, they need to be on an ACE or an ARB. They need to have smoking cessation if they were a smoker. They're probably going to be put on a beta blocker. There is a little bit of contradictory information on beta blockers post-MI in the research, but in general, they still expect to see the patient on a beta blocker or have it contraindicated. Fibrinolytic therapy received within 30 minutes of hospital arrival and primary PCI received within 90 minutes. That's what they call door to balloon time. I can tell you right now that most of the magnet hospitals are cardiac certified and they have this down to a science, and you can have a patient door to balloon time less than 10 minutes. I've seen it. It's pretty amazing. If their LDL cholesterol level is greater than 100, they will be placed on a statin at discharge. So again, those are nursing interventions that kind of go throughout all the different points of care. In the ICU, you're going to be monitoring the patient. They will be on continuous EKG because, again, if we've reperfused that heart, it is not uncommon for them to have dysrhythmias. VFib is your most common dysrhythmia after an MI. A lot of times you'll see PVCs, which may lead into VTAC, and sometimes you'll even see those prior to the patient going into VFib. So just be aware of that. ST segment, you'll be monitoring their ST segment for changes. And again, this is going to show you if you've got further ischemia happening. Pre and post cath lab, remember they're going to be giving an anticoagulant. So you must monitor these patients for bleeding complications. If they went in through the femoral artery, you're going to be holding pressure on that femoral artery. Now they have these cute little contraptions that actually inflate a balloon that pushes down on it. So back in the old days, we used to have to stand there with sandbags, I am not kidding you, on these patients. We had to stand there and physically hold pressure, and it was a lot of fun. You got to know your patients really well. But now they, like I said, they have these bands that fill up with a little balloon that presses right over the insertion site, which is great because you can see right through the clear plastic. You can see if they're having bleeding, if they're developing a hematoma, anything else that we want to do to assess that area where they had that big puncture site. Pre and post cardiac artery bypass grafts, that should be one word, bypass. Remember, that's CABG. So we need to look for reperfusion complications like dysrhythmias, chest pain, things like that. One of the best things that you can do for these patients is just to promote rest and comfort during that initial myocardial injury, like the first 24 to 48 hours. They're going to be on bed rest, but they still have to get up and move around. You don't want these patients to then develop pneumonia, because then they're going to be coughing and straining, and that just is going to be a whole big old mess. Keep them in a nice quiet environment. They might even benefit from learning some meditation or relaxation techniques. Slowly you'll increase their cardiac workload, so they'll walk just a little bit further, and then in a couple of days a little bit further, and then a little bit further. And the whole point is to get them to an acceptable activity level for getting them ready for discharge to home care, and they will probably be in cardiac rehab for a while after they get discharged. So here, teaching. One of the main things to consider is you have to adjust your teaching based upon what stage the patient is in their hospitalization. So you don't just start right off and say, this is what you're going to do, but we're going to have to wait 14 days. So you start off your teaching very slowly and incrementally. These patients just had a major life-altering event. And like I said, a lot of people are in denial. So they're going to have to come to terms with the fact that they just had a heart attack. You as the nurse are going to have to carefully assess their learning needs and help them set realistic goals. The timing for treatment is important because during that initial crisis, they're not going to understand new information. Try to answer their questions in simple terminology. Don't get all medical terminology on them, but don't just adjust it for what the patient needs from you. Your job is to guide them on what to expect in the course of recovery and rehab. Activity, they're probably going to be scared, so their activity levels are absolutely crucial during this time. You have to teach them how to balance out gradually ramping up their activity levels, but not pushing themselves. There are 3 different phases to rehab. Phase 1 actually begins in the hospital. Phase 2, which is considered early recovery, begins once they're discharged, and it'll last anywhere from 2 to 12 weeks. It's usually conducted at some sort of an outpatient facility. And then Phase 3, this is their long-term maintenance program. So this is an individualized physical therapy, education on therapeutic lifestyle changes, and any medication follow-up that still needs to happen. Please review these phases in your book. All right, so I just pulled your your Lewis book, and it's page 757 is where the table is that talks about the phases of rehab after an MI. So just for your reference. Okay. Sudden cardiac death. Well, as the name implies, this is a sudden disruption in cardiac function. Basically, you have a total loss of cardiac output, and as you can imagine, this is incompatible with life. A lot of times it is resulting from a variety of different cardiac causes. Believe it or not, an estimated 382,000 people, a little over that actually, experience sudden cardiac death every year. So in sudden cardiac death, there's a disruption in cardiac function which produces an abrupt loss of cardiac output and cerebral blood flow. So the affected person may or may not even have a known history of heart disease. It's often the first time that people who have heart disease realize that there's a heart disease, if that made any sense. Acute ventricular dysrhythmias like VTach and VFib cause the majority of cases of sudden cardiac death. The structural heart diseases count for about 10% of the cases, but patients in these groups include those with left ventricular hypertrophy, myocarditis, hypertrophic cardiomyopathy, so they already know that there's some heart disease going on. It is difficult to know who's actually at risk for sudden cardiac death, but usually patients with left ventricular dysfunction, which is an EF, well, even EF less than 30%, other ventricular dysrhythmias following MI, all of these have found to be the strongest predictor of sudden cardiac death. Other risk factors include a history of syncope, aortic stenosis. If you're a male, that tends to also give you a little bit of a strike, and if you have a family history of ventricular dysrhythmias. As far as management goes, people who actually survive an episode of sudden cardiac death, which it does happen, require a huge diagnostic workup to determine what happened. Most of them have coronary artery disease to some degree, so a cardiac catheterization is done to determine where the location and extent of coronary artery occlusion is. And if you'll recall, cardiac cath is when they go in through the femoral artery or through the radial artery and they look at the heart and they'll shoot dye through and watch the dye flow through the special x-ray to see where the actual blockages are. These patients can even be sent home with a 24-hour Holter that monitors their EKG for 24 hours straight. And they can also be ordered a stress test, which is where they get on the treadmill and are hooked up to the EKG and they walk and they try to induce the pain or the dysrhythmia. It can also be done with medications. A stress test can be done with medications, but I'm telling you what, it's very uncomfortable for these patients because they're sitting there calmly and they get this medication that makes their heart beat really fast, and it's very uncomfortable for patients. But if you're trying to find out what it is that caused your heart to stop quite suddenly, then I think I would withstand a little bit of uncomfortableness just to find out why. So here are some questions that you can go through. And this brings us to dysrhythmias. I will start part 3 with dysrhythmias. Thank you.